Good afternoon, everyone. I think we're going to go ahead and get started. I know the MPH students are just coming out of a class, so we'll try.
Not yet. They're not ready.
Say that again? Oh, I don't have to get real close. Okay, good. But that you just come out of a class, so we hope you've had time to get here, and some are still coming in, and we're still hoping for another one of our panelists to join in a moment. My name is Alice Levisay, and I'm an alumni from the class of 1992. Shh! You are supposed to provide a
model.
How do you say? A model of something. No, behavior. That's model exemplary public health professional behavior. But as you can see from the class of 92, we're rather exuberant and very excitable. And we hope that we can inspire some of the current MPH students to be as excited and to do interesting and wonderful things. So how we're going to do this session, we've got 3 panelists, of which we've got 2 here presently, and we hope the third will join us shortly, who we're going to ask to give a little bit of information and history about themselves and kind of the history of what they have done in the last 20 years since they graduated from their MPH degree in 1992. But before we get started, before I introduce all of those individuals, I wanted to also give you a little story about myself. So when I finished in 1992, which seems like a long time ago now, I did get married over spring break. That was very exciting. And I did go to class after I got married, but before I went on the honeymoon. So yes, there's always excitement to be had. But it got more exciting when in 1993, I went off to Cambodia and started work first with IRC. Nobody wanted to go to Cambodia in those days. It was a pretty dangerous place, and the Khmer Rouge was still quite alive and well. And by the time 1995 came around, I was still in Cambodia, but at that point got a job with WHO as a provincial health advisor, and I was very excited. I had always wanted to work with WHO, and this was going to be wonderful. And no sooner had I accepted the job and appeared on my first day of work, I went to the WHO office in Phnom Penh, and clearly something wasn't right. All the new provincial health advisors, there were 3 of us walked in, and they said, "Come into this room." And so we all marched into this room, in this meeting room, and it was full of all the WHO staff. And we had the regional director on speakerphone. In a WHO system, the regional director is kind of like God. He's an elected official. And very soon it became clear that the dengue outbreak was now a very serious issue. And we were not going to go to the provinces to which we had been assigned. We were going to go deal with the dengue outbreak. And then all of a sudden, these very big bags of money start coming into the room, jute bags of money. And we all start looking at each other and looking at these bags. And very quickly, the regional director starts saying, "Okay, each one of you provincial health advisors, we are going to assign you to a location, and you get 2 of those big bags of money, and you may come back when the epidemic's over." And we all looked at each other, and it's like, what? What are you saying? We know how the epidemic curve works, and this isn't good. You know, even if I have an intervention now, and this is not good. And we all had a good giggle, but what I did realize sitting there that day in a bit of panic was I started going through all the classes I had taken here. Yes, I'd had biostatistics by Marie Dina Rest. Check. Okay, we can do a little bit of that. Yes, I've had the following analytical thinking course by Dr. Renke. Okay, check. I've had the tropical public health disease course. Yes, we can do that. Check. Okay, we had health information systems. Yes, check. I went down the list, and by the time, then 5 minutes where I was like, well, okay, I can do this. I really would like to come home before the epidemic's over, and I would like to know a little more about those big bags of money, but I think we're going to be okay. I think I can actually use a lot of what I've learned here. So the moral of that story is you will use what you learn here. Learn it well, have it handy, and it may come in when you least expect it. You may need it. And never, always be prepared for the unexpected. Public health is not always a predictable profession. So, with that, I'd like to get started. Let me introduce the first panelist, Meg Doherty, who has her MD, PhD, and MPH from the class of '92. She's an assistant professor at the Johns Hopkins University School of Medicine and the Bloomberg School of Public Health, and has more than 20 years of experience in international public health, clinical research, and education in a broad range of topics, including HIV/AIDS, TB, STIs, maternal child health, and general infectious diseases. Meg was working full-time in Ethiopia from 2005 to 2010, as well as the Director of Clinical and Training Services for the JHU PEPFAR Technical Assistance Program. So Meg, I'd like to hand it over to you for about 10 minutes, and then we're going to go on to Yvette, and we'll see if our other panelist comes, Calvin. And then after we finish, I would like to then open it up for question and answers, if that's okay. So please, Meg.
Okay, thank you. And yeah, it's interesting. I'm very happy to be asked to come and speak to you, and I think I'm because I made it back to Hopkins and I'm still working here, I'm representing all of us who stayed at Hopkins in some form or manner, and there could be many people sitting in my chair, including I was looking at the people who enrolled in our class, and my division chief was a member of our class, Dave Thomas. Jerry Sugarman runs the Berman Institute, and I think there's many more. Parul here is running something as well. Ida has been running programs in Ethiopia, so I think I'm just representative because I don't know, I went to school for about 20 years, as well as got some experience. And I guess we had a long discussion about medical education and debt today, and I think I could give a lot of advice about what that means when you go to medical school later in life. So I was going to start with where I am right now, because currently right now I have a pretty interesting position where I'm in the primary division of infectious diseases, but I also have a joint appointment at the School of Public Health. And so about 20 to 25% of my time is actual still clinical time focused on HIV and infectious disease consults. So when I started out doing my MPH, I wasn't a physician. I was pretty junior. And I had, what sort of inspired me to come to get an MPH was I had been a Peace Corps volunteer in what was previously known as Zaire, but the Democratic Republic of Congo now. And it was there that I had all this exposure to HIV, maternal child mortality, infectious diseases, etc. And like Alice, but I didn't have any training, I was asked to do things like CAP surveys for HIV or do statistics for the WHO expanded immunization program. And I really had no clue what I was doing. And remember, this was before cell phones, before internet, before computers essentially out there. And so you were doing everything by hand. And so I said, when I was out there one time in the middle of Congo, I was like, I am going to learn how to do statistics. I am going to get some training in epidemiology. And when people come to my door and ask me to save their dying child, I'm going to figure out how to do that, because I was often put in positions where I couldn't do anything. So I did have a goal of becoming a physician and also using public health, and I think the PhD was sort of just a sidetrack for about 8 to 10 years. But that's what happens when you come to Hopkins. So I started at Hopkins fresh out of Peace Corps. I focused on epidemiology and infectious diseases while I was here. I got a lot of the quantitative skills that I wanted by taking all the biostatistics I could. I enjoyed it. People got to know me because I hung out in what was called the fishbowl then, because all your statistics was done with SAS on a mainframe, and the only time that it was really open and free to utilize was like from midnight to 4 in the morning. So I spent a lot of time there. And it's different these days. You could run a program in 2 seconds that it would take 40 minutes previously to do. So I actually got involved because I was very focused on community work. I got involved in the injection drug use and HIV epidemic that was happening here in Baltimore, and stayed on doing my PhD, working first with the needle exchange program and harm reduction, and then also starting a cohort for young injection drug users, and which was funded through CDC and was one of the first times that we were actually looking at adolescents and their risk for HIV, Hep C, and and Hep B, excuse me. And eventually along the way, I said, you know, we're getting all this epidemiologic and social and behavioral information about these 14-year-olds who are getting infected with HIV, and yet I'm doing nothing. They're not getting therapy, they're not getting treatment. And that's when I decided, okay, I can go to medical school, I'll do it. So for all of those of you who are thinking that you can't go back to medical school when you're over 30, you can. And as I was leaving Hopkins, somebody said to me, it will be 10 years before you start your career. And I said, no, it won't be. But yes, it is. And so I went to medical school and did internal medicine, and then came back to Hopkins for infectious disease fellowship. One, because I knew that there was a close collaboration with the School of Public Health, and I felt like it would be a good opportunity to be able to marry the clinical work and the public health work. I also liked the openness. I mean, I was at your esteemed competitor for medical school, both MGH and Harvard, which Hopkins hates right now because, just for the hospital people, Hopkins has been #1 for 21 years in the US News and World Report. And just this week, 2 days ago, MGH surpassed them as being the #1 hospital. And there was something that came out saying, we don't know why we could possibly be #2, and we're looking into all the reasons, but... And anyhow, so I was up at MGH and came back here because what I found in the system there is that the School of Public Health and the School of Medicine weren't really communicating very well, and I thought I would have opportunities to work in public health more so than I found when I was up in Boston. I mean, I think that's unique. I'm sure everybody has a different experience, and I felt like coming back here would be a good one for me. And it was, because essentially I think also the HIV clinical care situation in Baltimore, unfortunately, mirrors what's happening in Africa. I think the rate, somebody was quoting me for Maryland, I think the rate of HIV is something like 1 in 93 people in Baltimore City or Maryland in general, and that the rate of new infections is similar to that in Rwanda. So when we sort of think about going out to Africa, you know, we also have to remember that right here in Baltimore, there's a lot to be done. So, so we have to introduce Calvin.
You keep going. We'll get him right
We'll get there. So at this point in time, after doing a fellowship, I went over to Ethiopia and worked with Ida, who's in the audience here, on a program that is funded through the CDC, a PEPFAR, President's Emergency Program for AIDS Relief. And we essentially, grew from so in the country there were only 10,000 people on antiretroviral therapy, and we were part of a program to increase that. And now I think there's over 200 sites that Hopkins supports, and over 75,000 people on antiretroviral therapy. And so it's been a very successful program. And out of that stemmed a new initiative for medical education support, so training. So we set up and helped with Addis Ababa University to set up an infectious disease training program for fellows, and as well as set up, we're working on medical capacity building through education. And right now I'm traveling next week where we're gonna be doing a training on simulation, so that when we heard about this health resource disparity, where we can actually try to use some technology but really fill the gap of, you know, when there's one instructor to, 50 students and they're going on rounds together, how can we maximize and give higher quality medical education? So we do simulation, we do some e-learning, but we also do, mentorship on training of medical students and residents. And so that's where I am now. And so I think I'm in my 10 minutes.
Great.
And I'd be happy to take questions.
So thank you, Meg. Now I'd like to introduce Calvin B. Johnson, MD and MPH from the class of '93. Very glad you could join us. Calvin is Executive Vice President and Chief Medical Officer for Minsec Companies. He's also the founder and president of Altrae Strategic Solutions Group, a strategic consulting firm providing expert counsel in the areas of healthcare policy and practice. And he's the former Vice President and Chief Medical Officer of Temple University Health System. But prior to joining Temple, Calvin served as the 24th Secretary of Health for the Commonwealth of Pennsylvania, and he was the youngest person ever to hold that position. So, if I can ask Calvin to please grace us with at least 10 minutes. About 10 minutes. What you've done in the last 20 years, what MPH students might want to know.
All right, well, 20 years. Has it been 20 years?
20
really?
years.
Well, I can tell you 4 examples of what I've done the last 20 years were here a second ago, but I think they're off getting treats right now. But they'll be back in just a few minutes. Oh, they are. Stand up in the back. Where are my kids? Oh. Taylor, Alonzo, Winter. So that took a few years. And so first, let me apologize for my lateness. All of my former classmates are familiar with that because this is about the time I used to roll into class as well. But today we are on our way. We live in Philadelphia. We're on our way south to a family reunion. So this worked out perfectly for us. Well, almost perfectly, and so that's why we were a little behind, so I apologize for that. So back 20 years ago, when I left here, I went back to Philadelphia, which was my home, to train in pediatrics at Children's Hospital of Philadelphia. I had decided in my 3rd year of medical school, and let me just add that my tenure here was between my 3rd and 4th years of medical school. I was one, as my classmate Stephanie Factor there. And part of you'll hear through part of my pathway, Stephanie and I also ended up in New York City at the same time, working as well. So Hopkins folks end up everywhere. And so I decided that I wanted to go into pediatrics about my 3rd year of medical school, but I also decided that wasn't it for me, that there was something else I needed to do. And I tell the story that I kind of stumbled across the street from the medical school into the School of Public Health, and it almost literally was a stumble across the street, just to kind of hear and see what was going on in here and see if that might kind of fulfill this need I had, which I really hadn't defined. And ultimately it did. And that need, I come to find out, really was one focused more on population health than on the individual clinical delivery of clinical care for me. And health policy was really my focus while I was here. But what I did keep in mind was that I had the opportunity to bring something I believed additional, not necessarily unique, but additional from my perspective to the health policy table, and that was my clinical experience. So when I left here, I was committed to going and getting my clinical kind of bona fides, if you will, by going and doing a clinical residency in pediatrics and becoming board certified in pediatrics. From that point, when I left my clinical residency, I figured that was pretty good in terms of getting my clinical credentials, and I was ready to kind of get back into the public health waters. And I had an opportunity to go to New York City to work at the city Department of Health there. And I'll just take a moment and then speed up a little bit, because I'm sure you want to hear from Yvette if you haven't already talked, and then ask questions. She's brave for letting me go first, my good friend. So, but I got to New York City. There was, I'll put it this way, I was the last one in my residency class from Children's Hospital to have a job. It came, all of the folks who were going into academic medicine get their fellowships lined up early on, and just one by one, boom, boom, they land in their fellowships. Then folks who are going to do clinical practice decide on their job offers, and they decide on what practice they're going to join. And then there are folks like me who were holding on to that idealism that Hopkins had instilled in him, that he was going to go save the world in some other way. And I was holding out for that. And so, clinical residency ends June 30th. It was June 15th, and I was still waiting to hear. And what ended up happening for me was I ended up getting a job in New York City at the City Department of Health, as I said, a job that didn't exist before I had it. It was a job that was actually created for me by then Commissioner of Health in New York City, Margaret Hamburg, better known as Peggy Hamburg, who is now our FDA commissioner in this country. And the only reason she created the job was not because of me, but it was because of who sent me to her. And what I did when I left here, I did my networking, and I went to Karen Davis, who was the chair of health policy when I was here, had left and gone and was running the Commonwealth Fund in New York City. And what she did for me as one of her students, who she may have graded one of my papers, I swore she didn't know me, but she opened up her contact list to me. And that led to me having an audience with the Commissioner of Health of New York City. And I guess she was sufficiently impressed with me on my own to then be willing to stick her neck out and create a position for me. And then lastly, in one sentence, I'll tell you that I left there after a while, went back to clinical medicine in the academic world, taught at a medical school, saw patients at a children's hospital, and from there had the opportunity to serve as a public official when I was appointed to Secretary of Health in Pennsylvania by then Governor Rendell. I did that for about 5.5 years, much longer than I ever anticipated, much longer than anyone at Hopkins ever told me was the average lifespan. I should say lifespan, something professional lifespan in that kind of role for a public health official, and it really was. That was about 2 to 3 years. I was there for 5.5. I aged quite a bit there. You say I was the youngest one there. I was a lot younger when I started there than when I finished. And left there, and you heard kind of some of the things that I've done since then, and I'll be happy to talk more about it. But let me just end by saying that I know that I would not have been able to do those kinds of things. I know that many of those doors that opened for me would not have necessarily opened for me. I know the direction that I was pointing in, I would not have been pointing in if I had not had that foundation here and had that support from here, and then had the connections from here that helped to at least, open those doors. And then, of course, as you know, once you're in those doors, you better perform or you'll be out pretty quickly. But thank God for Hopkins for that. And so it's been 20 years already. Wow.
Thanks, Calvin. And let me now turn to Yvette, who, as Calvin said, was brave to go after her. Yvette has been a practicing biostatistician for more than 30 years. And in addition, she's a trained systems analyst and an injury epidemiologist. She's an alumni of this school, and she was also an employee of PAHO for 20 years, an international fellow of the Centers for Disease Control and Prevention's National Center for Injury Prevention and Control for 2 years, and has been an international consultant for the last 11 years. So, Yvette.
Thank you and welcome. It's good to be here. As you will hear from my accent, I am the exotic flavor for this evening.
There's a lot of exotic flavor.
That's true, but I'm representing all of them. I was one of the international students. I come from the Caribbean, actually from Trinidad and Tobago. And my background is a mathematical statistician, and by way of agricultural statistics, economics, and information systems, I landed a job with PAHO, WHO, Pan American Health Organization, World Health Organization Center, located in Trinidad and Tobago, called the Caribbean Epidemiology Center, which serviced 21 English and Dutch-speaking countries, starting from Bermuda in the north all the way down to Trinidad, and including Belize, Suriname, and Guyana on the South American mainland. I was hired as a biostatistician and placed in this epidemiology center. I had never even heard the word epidemiology before. So I was thrown into the deep end, given a job to do about which I knew nothing. But fortunately, I had a very good mentor. So he taught me about epidemiology, and he had an interest in injury epidemiology. But unfortunately, 4 years after I started the job, he died in office. So there am I, stuck in this job. I know a little bit more, but I know I don't know epidemiology. So what do? I was told, go to Hopkins. And I have not regretted it since. I came to Hopkins, met all these fabulous people, the faculty, and I learned so much. And I think what for me was the biggest thing was the fact that, as you realize, I came from other disciplines. By coming to Hopkins, I learned about health promotion, I learned about behavioral science, I learned about environmental health, I learned about occupational health, health systems administration, health services. I learned all of these things. And I must say they have stood me in excellent stead, because I went back to my job with PAHO, and I was able to provide service then and later on when I became an international scientific fellow with the Centers for Disease Control. And again after that, when I took very early retirement and decided I wanted to work for myself with people I like and doing the things I want. So I continue to provide biostatistical and epidemiological service and support, but I have been able to do it in such a wealth of fields, things ranging from cervical cancer screening, treatment programs in the interior of Peru, cervical cancer in Suriname. I've edited a manual, injury surveillance manual for WHO, and in fact right now working with them and the university in Great Britain to do an online short course in data collection for injury prevention. We've written other manuals. I've set up injury surveillance systems in Central America, in the US, and worked with partners in Africa to do the same. All of this to say that when you leave Hopkins, you have such a wealth of knowledge, and you have all of these experiences of colleagues and faculty to draw upon that you can do just about anything. Thank you.
Thank you, Yvette. So I'd like to open the floor for people who have questions or comments that they'd like to ask. But we would like to ask you to come to the microphone so that you can be heard, and I believe we're also being recorded. So questions or comments, please.
Were we so overwhelming?
Yes, obviously.
I want to just, I was hoping that Yvette could talk a little bit more about the importance of the colleagues that are your classmates.
Why'd you pick me, Stephanie? Actually, I think Calvin can speak better to the networking. I am from here. I'm not from here. So that for me, what it meant was that I could interact with people in the US, and hence I was able to make the connections with the Centers for Disease Control and the Injury Prevention. Through PAHO and WHO, I was able to network with other people. And the thing is, it's not just you networking, but you are also an avenue of networking for your colleagues, for the alumni who come after you, and even for those ahead of you. One of the weirdest ones I remember getting was a call from Ricky Fine, who at the time was Alumni Relations here at Hopkins, asking me, Yvette, what do you know about voodoo? Oops, not much. Why? Well, there was a patient at the medical hospital, at the hospital here, who was ill, was dying, and there was no diagnosis. There seemed to be no clinical reason for it, but the person had been a victim of voodoo. And since I was one of the Caribbean persons that had stayed in touch with this school, I became the expert on voodooism. So the networking is important, both you with others and others through you, so it's up and down. You're going to be in the middle, inside and out, and sideways. But the networking is critical, and you, as you heard from Calvin, it opened doors for him. So it makes a difference, and you'll open doors for others. Meg and Calvin.
I'll only add that someone like me who I've not been as diligent in staying connected like Yvette, and folks like Yvette have kept me tethered and connected in some ways, and you get that's a benefit as well. And I would encourage you to not make some of the mistakes that I made in thinking that one phase of your life is over or your education is over as you move on to the next, but truly make it a cumulative kind of story and picture. Now, I did take kind of a lasting piece from here that I met my wife here, or she was here the year after me, right? And Meg you were at my wedding.
I was.
Yeah, you were at my wedding too. So, yeah, and she's just been in my house and in my life and all kinds of stuff. And so those kinds of things happen, and those kind of connections are real and very important because, something happens in the time here. And I'll tell you, when we were here, that was 91, 92, with kind of the first of the modern healthcare reform eras. And I can remember all of that just like it was yesterday. And here you are here at a time where it's real healthcare reform. I mean, that's historic. And that's something that the context, the era, as well as the relationships, that is invaluable. And I encourage you not to let loose from that as you move on through your careers, but really hold on and stay connected to that because it will only be to your advantage.
Meg, do you want to say something?
I think I don't have too much to add except for it's also a really good social network. I think we were considered to be a very social class at that time, and we had many parties. And I think that I remember, because some people will come to me and asking advice about going to medical school or not, and they're in their throes of their MPH and say, the MPH is just so hard. I'm like, I remember it being fun, and I do think that that's one thing that you should think about while you're here is create a group and have fun, because it is kind of grueling, the sort of time frame of exam every 4 weeks or whatever, but I think my network from this class has been primarily social, but on the other hand, now I think that we're starting to get to a point where people will be coming to me and saying, "What can you help me? Can you do this?" And I'm like, "I need help," So, and in some ways, so you do realize that at some point you might be able to help other people, and it is good to keep those networks going. And at some point we do grow up, and so, but that's all I would add.
Thanks, Meg. Other questions, comments? Please come to the mic.
Hi, I'm Fatmata Darami, and I'm a incoming MPH, and I'm also currently achieving my MD degree, so I came here just like you, Dr. Johnson, and I'm also interested in pediatrics. So I would really like for you to elaborate on what you're currently doing with your work, since you kind of went through it real fast.
Let me first say, if you're doing this in between your medical school years, then you should definitely be having fun. Right?
By the way, there's something that Dr. Johnson didn't tell you. He was the MC for our Follies that year.
Yeah.
Leslie. So yes, enjoy yourself. What I'm doing now, actually, you'll be disappointed to hear, it really doesn't involve pediatrics. Is touching on public health. So let me just take a minute to kind of lead you how I got there, and then we'll see what I do next as well. But what I'm doing now is I am helping to run a company that is about a 200-person company that is a for-profit company that is in the business of providing housing and services, and we call transitional services for special populations. And those special populations primarily are offenders and veterans. And sometimes offenders who are vets and vets who are offenders. And what we provide, again, we provide stable housing, transitional housing, and support services, including case management services for housing, employment, et cetera, life skills. We also provide residential and outpatient behavioral health treatment, drug and alcohol, and mental health treatment as well. Our customers, aside from the vets and the offenders, are federal government, state, and county, local governments. And so that's what I've been doing for the last 2 years or so. And what I've found is, I've over time, I'll just throw in a little bit of my philosophy, and since you've opened the door and asking me the question, but I've come to believe over time that our social issues and our public health issues are problems that have been with us for a long time, and challenges that have been with us for a long time. They will not be solved alone by the government. They will not be solved alone by the not-for-profit or community-based organization sector. They will not be solved alone by the private sector. It takes true partnerships in the very real sense of the word. And for some folks, those partnerships have to be based on a profit motive. And so I think that the future of true public health and public health success lies in aligning all those kinds of motives and incentives to achieve the kind of outcomes that we all agree upon, and allowing within reason and with ethical and moral reasoning the achievement of certain specific agendas and goals as well. So I've been in the not-for-profit sector, I've been in the not-for-profit private sector, I've been in the not-for-profit public sector, I've been in government, pure and simple government, and I've been in the for-profit private sector. And nobody has the answer, but collectively, I truly believe those kind of things can happen. So my path has been kind of, winding, fun and winding, and I don't think it's over yet. But I guess the bottom point, or the final point, is that it really is the opportunities that you allow yourself to take advantage of, if you're willing to kind of open the door and open your mind to see where you can take those skills that you have and apply them most effectively. And it'll be a challenge in some instances, but I think that I encourage everyone to keep your mind and your opportunities wide open in front of you, because they need clear thinking people with the right motives, whatever you define as the right motives, are needed in every sector.
Thanks. Other questions, comments?
Hi, my name is Heather. I was actually hoping that you could provide some insight to those of us who are just starting out on this path, possibly any classes or any extracurriculars that you took while you were here that ended up directing or redirecting where you thought you were going to go afterwards. Thanks.
Okay, let's start. Meg, do you want to comment on that? We can go down the line.
Yeah, I think we had perhaps, we were listening to this morning, I think we might have had more of a focused MPH where we didn't have as many choices, et cetera. So I feel like for me, which helped with my direction, was really doing the more quantitative approach. I wish I had added in a little bit more of the qualitative or mixed methods kind of methodologies that are now being taught at the school, or added in things like cost effectiveness, because I think those are really useful in the field, especially if you want to go work internationally. We've been talking a lot about this, is people who are trained in epidemiology strictly are now being forced to rethink what is implementation science, and this is how we're supposed to be directing our interventions and how do we evaluate our interventions. And I think as an MPH, you should look into some of those courses that could help with that. Things like evaluation, mixed methods, qualitative cost effectiveness, if you are interested in really being an evaluator of the programs that you do. I think the one thing that I learned was it's really good to do interventions, but if you're not doing some sort of systematic evaluation of what you're doing along the way, you can spend an awful lot of money incorrectly or ineffectively, and in some ways, you could learn halfway during your process that you need to redirect. And if you don't spend some time on that evaluation process midstream, having those skills would be very helpful to any job and any career pathway, I think.
I would add to that, expose yourself and take every opportunity you can to get as much kind of finance background understanding. I remember auditing an accounting class, and what auditing meant for me back then was not paying attention, really. And so I would encourage you to take the opportunity for, if there is an accounting, if there is, definitely economics, anything quantitative and financially based, as skin crawling as it may be to you, depending on where you're coming from, dive in, because you know what, it won't continue to be that way. And essentially, health policy today, I think, effectively is fiscal policy, and you will be more effective in developing and implementing effective health policy if you understand the numbers and understand them going into it. The second thing I would encourage is, when I was here, one of our classmates, we had an interesting class. Maybe there's still, I'm sure your class is interesting. Classes are interesting in similar ways, but we had some orthopedic surgeons who were here getting MPHs, and in the early 90s, that just didn't make a lot of sense. We had Richard, we had Steve England, and so Steve England and I created an external internship down at the Department of Health and Human Services in D.C. We became speech writers for then Secretary of Health and Human Services, Louis Sullivan. And we literally wrote speeches for him. And it was a great place to be, because what I found out was that in a speech writing department or a communications department, you are exposed to every policy issue that comes to that chief executive, and you have to know what's going on. And so we got volumes of information in that we were reading and becoming familiar with, and we were penning policy-related. We may have even made some policy in what we wrote for him at times. But as speechwriters, and we ended up with his Secret Service detail going to events with him and things like that. But what it did, it really opened up a real world for us, the real world in terms of Washington, D.C., federal health policy. And if you look at a few choice words in some of those speeches, we actually had an influence and impact there. So think out of the box and go ahead and be innovative and be entrepreneurial and create things. And the great place about Hopkins, and I may be getting somebody in trouble here now, but the great thing about Hopkins is that you can push that envelope, and folks will look and say, you know what, that's not in our curriculum. No one's ever done that before, but you know what, go try it. Go try it and do it. And that was my experience.
I was unfortunate. I was never redirected. But I will admit, though, that there were a couple of courses I wish I had paid more attention to. And one of them was economics. Karen was right. The other one was health services administration, which I find is very useful if you're going to be working, particularly in the public health sector. It is a useful background, especially, too, if you have not worked, your way through the ranks of the health service. And I look at many of you, and you're much younger than I was when I did the MPH program, so I suspect that you don't have very much health service experience, so that Health Services Administration would be an excellent course to ensure that you do take. And I second Meg about the evaluation, and in fact, monitoring and evaluation is now a critical part of nearly every aspect of health. So if you're working in health, you must have some skills in M&E.
Thanks, Yvette. I think I'd like to also add my voice to this question, because I think, as Meg said, the curriculum that we went through is different than the curriculum you have now. You have many more electives than we had. We had a very heavy core curriculum and only a few things we could choose from. I think we benefited from that in many ways, but I would certainly say, and Calvin was talking about this, the importance in today's world of public health and public health policy, it's part art and it's part science. And you need to be good at both. And you need to come armed with your data, and that can be qualitative as well as quantitative, but you better have it, and you better understand it, and you better have it ready at all times. So when that speechwriter, or when you have that opportunity with that key policymaker or the Minister of Finance or a First Lady or a Secretary, you're ready to explain it, defend it, and have it there. And having the money information, the health economic information, again, it may not always be the class that you really look forward to, but it's going to be really important in the long run in terms of being able to inform policy, defend policy, and explain it. Because public health is not always sexy, and you have to at least bring the data to it to make it real. Other questions, comments?
I just want to thank you all for coming to speak with us today. I'm also doing this MPH program between my 3rd and 4th years of medical school. The plan was to go right back to medical school, but I'm already a little bit worried that might not happen. And I'm also keeping in mind the fact that I will have to take some time away from public health to go back and finish residency. So what I wanted to ask was if you have any advice for how to keep your skills sharp, either on the medicine side or on the public health side, while you're taking time away to do something else.
I'm going to direct that to our MDs down there.
Yeah, because I think this is a worry, because you get into medicine and you feel like you're, somebody showed me this figure that, back in the 80s and stuff, the amount of medical information was low on the scale. And now when you look at the medical information that's coming out, it's way up here. And I think they talked about it when I was in medical school, but I think it's really true now, is that you can't know everything. And you will not be expected to know everything, but you need to know how to find that information and how to search for that information, find it on, on websites or handhelds or this or that. And I think that that's how medicine is now practiced. And it's also, I think Calvin brought up something, is partnership. I mean, you don't practice medicine in a vacuum like you don't practice public health in a vacuum. So I think you rely on your colleagues, but you can take time off. I think I was quite worried. I went to Ethiopia after having done intensive medical work and clinical work for about 10 years or so, and I thought that that worried me. But I think what I tried to do was really, I took a position that was focused on clinical care and clinical work. I kept up with what we call CME, or continuing medical education, and we may have in the near future continuing public health education that we'll have to do. It's important to keep up with your certifications and take the exams when they come up so that you don't put that off, because I think that's an impetus to keep you current. There's always, everybody knows that nobody knows everything, so there's review courses that go on for 2 weeks that you can take to keep your knowledge fresh. And when I came back from Ethiopia to do clinical work here, I took time, and I took about 6 months to really get my feet wet again doing clinical care. And, I had colleagues observing what I was doing and grading my care of the patients. And you use colleagues. You call them and you say, what would you do here? What's your expert opinion, even though I'm supposed to be the expert in this problem, And everybody knows that they can't know everything anymore. So I think that's the one thing, is not to have too high expectations on yourself, and then to be plastic and flexible. Know that you can come back and forth. It's harder and harder. I think the traditional academic medicine career, where you have clinical care, you have administrative care, you have research, is much more difficult in this day and age to keep going. But there are people who do it. Yeah, it's possible.
I would agree with everything that Meg said, and I would also say that I believe it may be harder early in your career, before you've even developed those strong clinical skills and that clinical knowledge, to go away and then try and jump back in. Granted, everything does change very quickly. I mean, I stepped away from clinical medicine. I think now, actually, I'm going on 9 years, believe it or not. And probably within the first 4 or 5 years that I stepped away, all the cephalosporins had changed. And I was clueless as to, when I left, we were talking, it was ceftriaxone. Now, what are you using? See, thank you, Steph. Always there for me. Man, 20 years she's been there for me.
That's what networking does.
But to Meg's point, so you've got to be realistic about that. And some folks have said to me, at some point, you may need to decide which, if you're going to turn that corner all the way. For me, I haven't practiced clinical medicine in some time, and probably to the patient's tremendous benefit. And so, because it just wouldn't be fair. I realized at one point in my career that it would not be fair to a patient to still hold that, mantle of I'm a practicing clinical physician, as well as doing what I was doing on the administrative and policy front. It just would not have been fair to them. So I turned that corner. But I think that you have to make the decision for yourself. I would encourage, I don't know where you went, but I would encourage you, I don't know what your situation is, but I would encourage you to consider very seriously that if you're this close to finishing your medical degree, go ahead and finish it. The further away you are from it, the harder it is to kind of come back and do it. And that's why I pushed myself. And I remember having some very difficult decision points to make, but I pushed myself, go ahead, get your medical degree. Well, there were a lot of folks in my family that didn't really give me much of a choice. You were going to finish this. Boy, you've been this far. But you finished it and went on and did my residency right then. And I think today, because of the way that medical education and medical training really is expanding in so many ways, that there are more opportunities now to incorporate public health practice into your clinical residency even than there was when I was coming up, when I really felt like I had to put it on the shelf for a time. But now, if I look back and look at all the attendings I had and during my residency program, they all were at that time going back and getting masters in epidemiology or masters in public health, and so now that's kind of all part of what they do. So they think very differently about it.
So, our time is, Leslie's, okay. I'm with the program. I'd like to thank our panelists. Who've done, I think, a great job. I certainly hope it's been of use and value to the MPH students who are here today. I know we're going to break and go into a reception, and please also feel welcome to access us, access the panelists, access other alumni who are here. I think all of us would be very happy to talk to any of you and provide information or advice as best we can. What? Oh, Yvette wants to provide one more piece of advice.
One parting piece of
and
advice.
And then you must, wait, but I must also say, alumni, you are not allowed to leave the room, Leslie says, including Calvin, because a photo will be taken. So I'm going to hand over to Yvette, but no alumni are allowed to go.
One parting piece of advice to current students, and that is actually two. One, nothing that you learn here will be wasted, no matter how irrelevant you think it is now. Nothing. And the second thing is, do not ever throw away your notes. Keep them.
So please enjoy.